First of all, let me thank Clay and Ray Greenberg for sponsoring this event. It was Clay's notion to create a lectureship, an endowed lectureship for the future, and I'm absolutely thrilled that that's worked out, and there'll be adequate funding to do that. And I want to thank all of those who contributed to that activity. I want to thank the speakers from yesterday, today, from last night. Just a fantastic group of people who had very important things to say. I think the format was terrific. This conversational format worked beautifully. I'm going to break the tradition and use a PowerPoint because I tried to create something before I knew what would be discussed. And I'm going to go through it fairly quickly because I'm just going to try to hit some of the high points, many of which have been made. But I want to take the opportunity to try to put that into an oversized, an overlying perspective. I just want to remind you that I am a director of United Health Group, an insurance company and analytics company. Here we go. 10, 15 years ago, the literature was filled with discussions about the end of academic health centers. There was all kinds of discussion that the environment was changing so rapidly that these centers were in serious trouble. The fact is, they have emerged stronger than ever in most cases. Not at all, but in most cases. And I have great confidence in the future of the academic health center, which includes the medical school, but also includes, as Jean points out, a number of other health schools, hospitals that are part of the organization, and so forth. I'm particularly excited about the Dell School because some of you probably are aware that this is the first medical school established on an AAU university in almost 50 years, which means that it is on a high quality platform with opportunities with mature schools in the institution, many of which have been mentioned in terms of those kinds of interactions. And so if the Dell School does it and does it well, it's going to have an enormous impact, not only because of the Dell School, but because it's come from the University of Texas at Austin. And I think that's a very important element. There have been lots of medical schools established in the last few years. Many of them are community-based schools, regional schools, and so forth. But this is the real thing. And its impact, I think, can be remarkable. Now, Peter Braun beat me to this punch. Some of you remember that until the late 19th century, there was no distinction between public health and medicine. When John Snow invented epidemiology and took the handle off the Broad Street pump, he was a physician who gave anesthesia to Queen Victoria through 2 births. Medicine and public health were inexorably intertwined. And it's my hypothesis that as disciplines, that's going to have to come back together again. The notion that medicine is about that single doctor and the single patient that Elliot Fisher talked about versus populations is going to have to change. And the individual dealing with the practitioner, whether it's a physician or others who are dealing with individuals, are going to have to think in the context of populations. At the same time, biology is affecting public health in a big way. It's interesting that the School of Public Health here at Houston, the parent school, is headed by a dean who's a geneticist. And it's very clear that many of the activities that go on in public health will have strong biomedical implications. So the notion that health versus healing is a dichotomy is a false dichotomy. And it's one that's going to have to change. Now, there are lots of ways to do it. At Health Science Center San Antonio, we currently have about 115 MD MPHs. We expect that there will be MD MPHs here over a period of time. And these are people who want an MD and the public health training. But at the same time, as I think Peter and others have suggested, we're going to have courses, we're going to have programs which allow one to understand epidemiology, that understand the use of medical statistics, that understand the relationship between care and cost, and the kind of experience that's going to be essential in this new environment. Education in a big data world is going to also change significantly. All this data that is going to be collected, which is going to have to be used in a practical way, both to ask questions and to improve care, is part of what, in fact, physicians and other health providers have to understand. Problem solving is important, and we want our students to problem solve. At San Antonio, they have a wonderful program in which students from a variety of disciplines come together and look at medical errors and try to dissect what the role is of the various players in how the error occurred and how, in fact, it can be prevented in the future. And there are now programs for clinical safety and effectiveness throughout the program, throughout the school. But the point is that in an information environment, the ability of students, to know where and how to look, how to evaluate data so that they can operate in a flipped classroom. By a flipped classroom, I mean one in which there are essentially no lectures, there are essentially no PowerPoints. There is an opportunity for the student to get the facts and evaluate the facts on their own, and then come to the classroom and apply those to problem solving. So that notion of understanding how and in what way to get and use information is going to be critically important. As I suggested in a couple of my questions, I strongly believe that we need to do far more in the way of ambulatory education. And I would suggest that we'll talk more about partnerships in a moment, but we have some examples. For example, the Austin Regional Clinic, in collaboration with the Employees Retirement System, has 2 large health homes of about 25,000 individuals. They're practicing team care. There's no reason why medical students can't rotate through that activity and learn about it in those environments. There are a variety of opportunities because this medical school is going to need to have medical homes or health homes established. It's going to be involved in ACOs, either directly or indirectly. And one of the best ways for students to learn would be to participate in those activities and learn about it in that way. We've already made reference to team care and interprofessional care. I think John Luke, working with Sue Cox, has developed a wonderful program here in interprofessional care because it's a 4-year program. It starts with a fair amount of didactic and clinical activity, but merges into a practicum. It's very clear, for example, that the folks at Rochester years ago put together groups of students from multiple health professions and sent them out to the community to find out how a problem would be dealt with in the community, and learned about the role of the various health professions on an ambulatory basis in terms of providing care. The same thing can happen on an inpatient basis as Jean suggested, but I think the point is that there are a variety of experiences that have to include continuity experiences. And again, I think Sue and her colleagues have developed a very nice approach to continuity experiences because the business of seeing different patients for brief periods of time is not a way to teach the kinds of healing environments that and health environments that we want to create. And I want to emphasize the notion of accountability, particularly with graduate medical education. The point that Janet was making about preparing residents, for example, for understanding finances, delivery models, things of this sort, is increasingly important. The Council on Graduate Medical Education, the ACGME, is now recognizing that that has to be an important part of a resident's education, that we're not properly preparing them for practice, and the $13 billion a year that's spent has to be done in a much more accountable way, which is reflected in the report that Kathy Dracup worked on, and which made it very clear that we were not meeting our responsibilities, and if we expect the federal government, in one form or another, to continue to finance residents, it was going to have to be under circumstances in which they were, in fact, prepared for the kinds of delivery models, the kind of reimbursement models, the kinds of approaches to care that are important. We've hit on a number of issues with relation to research, and I want to make 2 or 3 points. One, the randomized controlled trial is fantastic. If you want to prove whether a particular drug or therapeutic intervention works on its own merit, that's terrific, and fully support that. But it doesn't tell you anything about whether, in fact, it works in practice in the community. And the question is how and in what way we can continue the kind of effectiveness research, which is cost effectiveness research, in the context of the activities of the medical school. And if the medical school is responsible for populations, either directly or in partnerships, there are a number of ways, and Clay made reference to this in his closing comments, to design approaches to determine whether an intervention works in the real world, as opposed to in a randomized controlled trial. There are all kinds of examples of the difference between what happens in a randomized controlled trial and what happens in real practice in terms of issues with comorbidity, biases that people have about patients' ages when they're treated, a whole variety of issues of that kind. And we made reference to this again yesterday, but I think it's critically important that we be developing information and doing studies about the effectiveness of treatment, including quality, safety, and things of this sort. And what I would suggest is we need to do a better job of networking among the UT medical schools and the UT campuses in doing that. There is no reason, Kevin Bostic pointed out the discussion that he had in orthopedics yesterday morning. There's no reason that we can't work out collaborations with the orthopods at all of these campuses, which had 2 effects. One is you can still study what's going on in your own institution, but you do it simultaneously in multiple institutions. You now have a large database, you now have better opportunities for comparability, and it may be hard to do. We may have to do something outrageous like go out of state or work with Baylor. But the point is, one way or another, we need to satisfy Mark McClellan so that he'll recognize that the way in which this is designed has some applicability, is publishable, but actually moves the agenda. I think it's critical to work with hospitals so that they have not only their quality group, but within the hospital, they have an understanding about how to design their interventions in a way that are likely to be evaluable. They don't have to become full-fledged researchers, but the quality folks are investing all kinds of time in putting these interventions in place. I'm delighted in the UT system, for example, that all of the medical schools now have associate deans for quality improvement. We have medical schools where every department has a vice chair for quality. All that's very good. The question is, can they make the jump so that they can design their activities in a way that we can draw conclusions in a timely way? I would suggest to you that we need to face up to the business of IRB approval for some of those studies, if they're in fact going to be controlled in some way or another. But it should be possible to have a collaborative IRB involving multiple institutions so that you can put a intervention into a particular institution via that IRB and then generalize it to a number of other institutions. But I think we clearly need to be able to take advantage of the advances in safety and effectiveness and find new ways to do that. Clay is extraordinarily interested in translational research and the applications of research to care. Again, what we need to do is to be able to find new methods to do the research that can be then applied. And now the research options are enormous. There are research designs which allow you to use very small numbers under certain circumstances, if you do it properly, to draw meaningful conclusions. I enjoyed the discussion about siloing in our institutions and how to avoid it. My own view is that we're going to have matrix organizations in this regard. You're not going to get rid of surgery as a discipline. Internal medicine is still going to want something to do with its tradition and its fundamental values. On the other hand, if you have product lines, which are realistic product lines, that's much better for the patient in terms of getting continuity of care, in terms of, MD Anderson probably is the best developed example of that in Texas, in terms of the way in which you can go onto a floor at MD Anderson and get your mammogram, get your breast biopsy, get the consultation, get the team to care for you, the social workers involved, the lady who's experts on wigs helps you determine whether you need a wig during your chemotherapy. How the whole thing, that whole product line is put together, which brings together people from a variety of disciplines at the same time that one may have an identity in terms of a particular department. And I think matrices can work. One of the challenges we've talked a little bit about is that there are a whole range of reimbursement models, and it's my hope that the medical school will experiment with a number of those models. There's no reason that one can't, working with its major partners, both on an ambulatory and an inpatient way, to do experiments with regard to gain sharing versus if you're going to develop health homes, for example, which I think the school should do, that when one would have hybrid models in terms of capitation and fee-for-service. I don't know which one and where the balance needs to be. I do know that fee-for-service as it exists now can't survive. We're going to move away from it. The question is how fast, how completely, and the medical school ought to be working on experiments to make some of those conclusions, as well as figure out ways to pay for health maintenance, including how you reimburse teams, how you reimburse groups. And again, many of these things can be done in collaboration with other organizations, and this emphasizes the importance of strategic alliances. The fact that the Dell School doesn't own its own hospital is both an advantage and a disadvantage. Right now, there may be, in fact, reasons that it's more of an advantage than it is a disadvantage, because you're fortunate in having an extremely expert team who know how to run a very successful hospital operation, who are also committed to care of the population, who are prepared to do experiments. And many of the things that you want to do, you can work with the Seton system, for example, as well as other organizations. But that also includes practice groups. I've already mentioned Austin Regional Clinic, but there are a number of other practice groups with whom alliances can be struck, as well as other health systems. And we're seeing that across the UT system. Southwestern has just made a deal with Texas Health Resources. We have expanded activities in San Antonio and in Houston. And those give you an opportunity to do experiments of a variety of kinds. Don't overlook insurance companies. Again, remember, I have a conflict of interest, but the reality is that insurance companies can be your ally. And if you get involved in care of a population, whether it's an ACO, a health home, or some other mechanism, you may very well count on and work with an insurance company to do a good deal of the actuarial work that's required in order to do the analysis that you're talking about. I mentioned the employees' retirement system. The database that's available there on a day-to-day basis is extraordinary in terms of affecting care. They can see emergency room utilization day by day. 1 month when the number of patients with headaches show up in increased numbers at their emergency room, they recognize it immediately and can immediately create a program to deal with headache on an ambulatory basis. Whatever the problem is, you can identify what's happening very quickly. Those kinds of databases are going to be important, and I believe that you can create a variety of new configurations which are patient-centered, team-based, and evidence-based as part of those alliances. Now, one of the important alliances is with the community, and one was talking about what can you do with the community. Well, I would recommend you go look at Brownsville, Texas, which is one of 6 institutions that received RWJ awards. What they did in collaboration with Joe McCormick and the folks from Houston School of Public Health was create a community-wide program to improve health. They do have a farmer's market. They do have hiking trails, biking trails. They have programs for citywide weight reduction activities, increasing exercise programs, programs for the elderly. They've worked on sidewalks and so forth. And they're a model community which is now being extended to McAllen, Texas. So there's a lot to learn in terms of South Texas, not only the ACO that was mentioned yesterday, but the opportunity to work with the community. Austin's a great community to try to do that with. Not that the politics are simple, but there is a willingness in this town to experiment, to do things differently, and they would be very much like to be the center of attraction. Clearly, to do all of this, we have to recruit and retain the best individuals, but once again, we have to face up to the notion that the successful academic health center cannot rely on triple threats. People who can do research, patient care, teaching, all at the level of excellence that one would want for each of those alone. Finding ways to identify and reward the teachers continues to be a challenge. One of the reasons we created the System-Wide Academy of Health Professional Education, which is a peer-elected academy, was because we wanted to create a situation in which an individual who was an outstanding teacher could be elected by their peers for recognition, and that could be used as part of the promotion decision. We need to do more of that, but we need to also heighten the requirements for it and expand the breadth of it. We now have academies at all of the health campuses. I suspect that since Sue Cox was a former president of the System-Wide Academy, we're likely to see one at Dell at some time in the future. But the impact of the academies on the individual campuses has been remarkable in terms of carrying out educational programs. And I think that they're important because they do combine recognition with peer review, which is what Dr. Freeman talked about. Healthcare is clearly a global activity today. Countries across the world continue to look at differences in terms of healthcare delivery models, reimbursement models. You go to Britain, they're changing it all the time, trying to experiment and do some of the things that we're doing. But the same thing is true in other countries, including developing countries. The notion of public health in the medical system has been very well developed in a number of countries. Probably one of the best examples is Ben Gurion University in Israel, in which the medical school is in fact the public health agency for the Negev, for that whole area of Israel. There are other examples of that around the world. And so on the one hand, our students want experiences in a variety of places around the world. And on the other, we have things to learn from it, which include some sense of responsibility. The recent Ebola outbreak clearly demonstrated the ease with which an issue that develops in a far off place becomes an issue in Texas literally overnight. And we're very proud of the fact that Galveston is on the cutting edge of that kind of infection. But again, Southwestern has developed a resource for that kind of infectious disease, all of which is going to increase, and Zika is a good example of that. We need to be able to respond to those kinds of things as institutions very quickly and to come up with innovative approaches to do it, mobilizing as much of the talent as we can. One of the interesting questions for me is how all of this interacts with professionalism. Talking about professionalism in medicine, on the one hand, it's very clear that some of the traditional aspects of professionalism have changed. Until recently, fairly recently, what was a profession? Well, it was an entity which had a body of knowledge which was known unto the members. They were responsible for conducting their profession in a way that was policed by other members of the community, that profession. They were in a responsibility to place the interests of the patient or their clients above their own, so that altruism was changing. Now, that's going to be changing dramatically. First of all, patients have access to almost all the information we can get, and in fact, many times they come in, or at least I get calls from them saying, I read about such and such, do you think that would be good in terms of changing my treatment plan? And I have to say, wait a minute, well, I looked that up. We have to teach our students to be able to say that too, because the patients, my granddaughter developed a rash. Pediatrician diagnosed a relatively uncommon rash. Within 30 minutes, my daughter-in-law was in a chat room with a whole bunch of mothers whose children had that rash. The notion that the loyalty of the profession is only to the individual has to be reconsidered. There is a responsibility of the profession, in my view, to the community as well as to the individual. And we're going to have to weigh that. That's something that the AMA is not going to want to talk about. They will fight that tooth and nail. But I find it remarkable that they don't object if you report a communicable disease, but at the same time, taking into consideration the other elements with regard to the cost of care, the options for care and so forth, in terms of benefit, is something that they don't want to talk about at all. And the notion that if there's something to be spent, it should be spent, is not something that we're going to be able to live with long term. I think the issue of diversity in our professions is critical. And again, going back to the discussion that we've had about caring for the community, it's clear that we've got to find ways to make our student body more diverse, more appropriate, more culturally sensitive, because we can't meet the responsibility to this very diverse population without some reflection of what the population is that we're caring for. So I am very optimistic about the future of academic medicine. The question from my perspective is, are we going to be leaders or are we going to be followers? Historically, we have been on the cutting edge of new technologies, new therapeutics, new techniques, and we've been fantastic in that regard. Until recently, we have not been on the cutting edge of how to improve healthcare delivery. Only some institutions have studied it, and what strikes me, and we mentioned this yesterday, often they study it nationally or in someplace else, as opposed to their own institution. The question for me is, how successful can we be in doing that? I'm very excited because I think the dean and the people around him clearly espouse a desire to be leaders in this regard. And that's going to require risks. That's going to require experimentation. Not all of them are going to work. Well, that's okay. Not all your experiments work either, whether you're in the laboratory or in the clinic. But the point is that we need to take some risks on how we deliver care. I don't know whether it's going to be a health home or an ACO or something in between or something entirely different. But we ought to be able to come up with different ways to deliver that care. At the same time, we have an opportunity to create new relationships, new alliances, to take advantage of resources, and to do that very early in the history of the school will be critical, because being seen as a reliable partner who can deliver will be an essential feature as to whether those relationships will continue. Thank you very much for being here, for being willing to stay to the end of our drama. But I have to say again that I'm just thoroughly pleased and delighted with the outcome, and I look forward in future years to having someone come, or a group. I mean, who knows, maybe we ought to have a couple of tag teams, as long as we're talking about teams, but having people stimulate us in this regard. Texas needs leadership in health services research and research in healthcare delivery. I think the Dell School, with the addition of key people and the leadership of the Dean and Mark and some of the other folks that are here, can provide that leadership, and I'm very excited about the possibility. Thank you very much.